everyone. Today I'll be reading the article India's Winding Road to End TB. So, the last year, tuberculosis, that is TB, emerged once again as the leading infectious disease killer globally. The goal, i.e., end TB, targets 90% reduction in TB deaths and 80% reduction in new cases, and zero TB affected families facing catastrophic cost by 2030. So, seem to be a distant dream. So, in 2018, India extended the highest level of political commitment for this cause by pledging to achieve end TB target on an accelerated timeline by 2025. However, the COVID pandemic was huge pushback to the efforts. So, according to the World Health Organization's Global Tuberculosis Report 2024, India continues to lead the global TB burden, that is 26% of the cases, and it is also the hub for drug resistant TB, also called the DRTB, and the TB deaths. While ambitious policies and initiatives are rolled out from the national level, the ground reality in India needs to be better understood to translate them into effective interventions. So, the first is focus on vulnerable groups. India's National Tuberculosis Elimination Program clearly defines the high risk or vulnerable groups that are at high risk of contacting TB and developing adverse outcomes. Dr. Pavitra Mohan, pediatrician and founder of Basic Health Services, a non-governmental organization working in South Rajasthan, says that we could around 10,000 per person with TB in our clinics every year. We get around 10,000 persons with TB in our clinic every year, and many of them have severe lung damage owing to fine dust inhalation from mining and stone carvings. They are risk to TB due to contributory factors like silicons, like undernutrition, overcrowding, and uncontrolled comorbidities like diabetes. Migrant workers also have an added advantage of poor access to healthcare facilities. Dr. Mohan says that they further go back to their native places if they fall ill, and hence it is not easy for healthcare delivery system also to keep track of their treatment. So, while a lot of attention is being paid to tackling undernutrition among the persons with TB, a host of other contributory factors in each geography needs to be addressed, requiring multi-sectoral action. So, TB is a curable disease with effective and free drugs from NTEP. A significant achievement for India is the treatment initiation is more than 95% of notified cases. This is possible over the years. This was possible over the years by establishing an exclusive procurement and supply chain system for the NTEP. However, in 2023, there was a countrywide break in the supply chain. It is still continues in many paths. Shortage of key drugs in the centers, many of which are unavailable in the open market, left the beneficiaries and their families in a struggle. Nandita Venkatesan, the data journalist and two-time TB survivor, says it takes many a mile for WPTB to reach the finish line of the treatment, compacting a wide range of side effects. Shortage of such critical medicine disturbs the treatment, risking resistance to antibiotics and poor disease outcomes. However, having to buy drugs from outside leads to catastrophic health expenses. On extrapulmonary TB affects any organ of the body like the lymph nodes, the kidney, the brain, the spinal cord, the bones, the joints, and the skin. However, the NTEP's main focus has been on pulmonary TB affecting the lungs, as it is the most common and transmissible. The share of EPTB is about 24% of the notified cases, but with the wide geographical variation, it is often missed, delayed from being diagnosed due to symptoms which are vague and mimic other diseases. Dr. Deepak Chandra Banani, a surgeon working in rural Chhattisgarh, says doctors in Indian setting should have a high index of suspicion for TB in the case they see. Proper history taken through a clinical examination and simple tests such as pus staining from a non-healing nuclear can help diagnose TB. But sadly, we wait for expensive advanced tests such as start treatment and depend heavily on specialists to diagnose, leading to substantial delays and advanced disease. He lays emphasis on training of general practitioner to pick up EPTB at the earliest and of the need to sensitize frontline workers and integrating EPTB into their screening algorithms. A study by Daniel and colleagues in Mumbai shows that only 35% of the private practitioners and 75% of the government doctors could correctly diagnose a patient presenting with classical symptoms of TB. Dr. Vasundhara Rangaswamy, a microbiologist working in rural Chhattisgarh, says the reluctance to notify the disease further impacts diagnosis as private practitioners prescribes antibiotics and refer without any diagnostic tests. TB is an area where guidelines are updated quite frequently. However, studies done by Shah and colleagues and also Hermats and colleagues show that the shortage of adequately trained human resource is a major challenge affecting implementation of the NTEP. Dr. Rangaswamy says molecular tests are expensive and often take time to access as they are mostly available only at district level. Results take a time due to heavy workload and shortage of trained staff. In effect, patients have to travel and incur more expenses. Dr. Mohan says that the CBNAAT, the cartridge based nuclei acid amplification testing, and the Trudent machines are not available at many places. And very often, when a machine is available, the lab technician will not be there, and if the lab technician is there, cartridge supplier for the test would not be there. The staff pattern with the NTEP does not meet the growing demands, with most of now having more work. What needs to be done? Ownership at all levels is essential to make programs work. Idukki district in Kerala collaborated with Kudumbashri, one of the largest women's self-help network in the world, for their TB elimination efforts. This resulted in widespread community participation and advocacy for government leadership levels, created a huge impact. It helped us achieve our target and sustain the activities, says Dr. Sensi B, former district TB officer for Idukki district and current assistant director, Kerala Health Services. She says advocacy by political leadership helps in providing platform for cross-learning from best practices across geographies, but program implementers will have to go beyond their routine work scope to achieve this. While the chance of ending TB by 2025 look bleak, there is some hope. India's case notification reached the highest level and deaths due to TB declined by 24% as compared to 2015, which is way more than the global decline. The administrative level of the NTEP are designed to adapt to the innumerable contextual challenges. New bodies of knowledge from different parts of the world need to be considered. Vietnam, a high burdened country, recently showed the effective use of active cases finding for TB among general population so that targeted interventions could work better. Perhaps India too needs to restructure and redefine its many conventional frameworks to combat this deadly disease.